Over the past 30 years, I've spent more time arguing about nutrition than virtually any other topic except for maybe fluids. Everybody has very strong opinions on this subject, but those opinions need to be tempered by the fact that there is a large array of high quality evidence now published on these topics. This is a multi-part module on metabolism and nutrition in critical illness, and this particular tutorial looks at feeding the critically ill patient the basics. Previously, I discussed the problem of critical illness cachexia, why our patients lose so much weight when they're in the ICU and subsequently, and this is associated with a prolonged flow phase in critical illness that increases blood glucose, protein catabolism, and fat turnover. That glucose is needed for the inflammatory response, so our bodies change the way they approach metabolism by initially using a lot of carbohydrates derived from glycogen and then from gluconeogenesis, and energy for normal body function is derived from muscular protein catabolism and to a lesser extent initially from fat mobilization. So there is a loss of lean body mass, and when that mass is restored, muscle strength is not as good as it was previously. Early mobilization enhances strength, but it doesn't improve outcomes, and feeding strategies need to be tailored to the patient, what they need at that specific point in time, and how they're going to behave into the future. Let's look at a clinical scenario. Emilia is a 73-year-old woman who had influenza last week, and now she has deteriorated progressive shortness of breath and hypotension. She has community-acquired pneumonia and septic shock. She's in the ED with acute hypoxic respiratory failure. She started on norepinephrine, noradrenaline, and she has failed high-flow nasal oxygen therapy. She's now intubated and mechanically ventilated. At the time, a nasogastric tube was inserted, and a question arises on all of these patients every day. When do we start feeds? By which route? And how much nutrition do we give the patient? And I'll cover all of this in the next two tutorials. In this particular tutorial, I'm going to discuss nutrition assessment in critical care, how many calories, how much protein, what route of nutrition are we going to use, and with respect to enteral nutrition, are we going to use a pre or post pyloric feeding approach, continuous feeds or bolus feeds, and what do we do about the question of gastric residual volumes? In acute critical illness, body weight does not necessarily change. In fact, it may increase due to fluid accumulation, but there is a devastating loss of lean body mass with a relative preservation, at least in the early stage, of fat body mass. There is catabolism of skeletal muscle, despite very high levels of circulating insulin. A significant source of energy is derived from the breakdown of metabolic and inflammatory waste products, a process known as autophagy. Autophagy is fully adaptive, and interfering with it with poor feeding strategies worsens outcomes. There are three effective stages in critical illness: an early phase in the first 72 hours, then a later phase up to about 7 days, then a recovery phase, hopefully after 7 days. So our bodies are always using carbohydrates, proteins, and fats for energy in both health and disease. But in that early phase of the stress response and in critical illness, the relative ratios vary depending on what point in the timeline the patient's physiology lies. The early phase is dominated by carbohydrate metabolism, but that rapidly depletes glycogen stores. So by the time that second phase occurs, most of that energy is derived from muscular protein and fat. In the recovery phase, by far the majority of energy is derived from both protein and fat, and overall energy requirements increases. And that makes the assessment of how many calories the patient needs extremely variable, and it's determined by what state the patient currently is in and what stage they are in their critical illness. Homeostasis refers to basic life functions: breathing, circulation, and the brain. What goes on in the liver, the kidneys, and everywhere else. and the patient will have an underlying basal metabolic rate that is determined by homeostasis. The basal metabolic rate is the number of calories that are required to maintain homeostasis, and that's about 2/3 of total calorie consumption. In critical illness, there is hypercatabolism, so total energy consumption increases, but due to autophagy, a significant portion of those calories come from tissue consumption. The junk or waste products associated with autophagy must be cleared as they may be toxic. Traditionally, we have calculated basal metabolic rate to figure out where the patient starts, and there are lots of equations for doing this, starting with the Harris-Benedict equation from 1919. This is a problematic equation because it is not usable across a wide range of different genders and ethnicities. So the most popular calculation these days that is used in clinical practice in the part of the world that I work in is the Henry calculation, the so-called Oxford equations. That uses height, weight, age, and sex to calculate basal metabolic rate. These are the Oxford Henry calculations. Pause the video if you want to examine these numbers. A simple alternative strategy that you can use in your ICU, particularly if there's no dietitian available or you're too busy, is to calculate total energy requirements by weight. The standard figure quoted by everybody is an energy requirement of 25 kilocalories per kilo per day. It's never clear whether this is actual, adjusted, or ideal body weight. But in general, if the patient has a normal body mass index, actual weight is used. If they are obese, a slight reduction is applied, and if they're underweight, the number is increased by 2 or 3 calories per hour. Most strategies using this method will then use a phased approach to calorie intake. Energy delivered gradually increases as one goes through the days since admission to the ICU. During days 1 and 2, if started, the target is between 25 and 50% of the usual calorie goals, about 12.5 calories per kilo. Between days 3 and 7, the target is between 50 and 70% of those estimated energy targets, about 17.5 calories per kilo. By day 7, you need to be at full feeds, and the target is full estimated requirements of 25 kilocalories per kilo. Is there a better way? Well, there is, and it's known as indirect calorimetry. Indirect calorimetry involves the use of a machine, a metabolic cart, to calculate energy consumption by the patient. In mechanical ventilation, we're able to accurately measure the amount of oxygen that the patient consumes and the amount of carbon dioxide produced. And then an equation is used, for example, the Weir equation, that converts gas exchange data into energy expenditure in kilocalories per day. The resting energy expenditure equals 3.94 times the oxygen consumption plus 1.1 times the CO2 production. There is no nitrogen or protein component to this. In the past, calorimeters were built into ventilators, and then we measured nitrogen balance doing 24-hour collections of urine to calculate nitrogen. This is problematic now because we're quite heavy-handed with diuretic agents these days, so that number isn't what it used to be before we used to diurese patients so aggressively. This is one of what I expect will be a series of new metabolic carts used in the ICU for indirect calorimetry. You may already have these in your ICU. If you do, please use them. There aren't a huge volume of high-quality research studies that have looked at metabolic carts, but a 2021 meta-analysis suggested that indirect calorimetry-directed therapy reduced short-term ICU mortality, whatever that means. To date, I'm not aware that indirect calorimetry has been shown to reduce length of ventilation, hospital stay, etc., but I will do a full tutorial on this approach in the future. Given that patients in the ICU seem to use an awful lot of protein as a source of energy, one would imagine that we should be giving patients lots of protein early in their stay. So let's have a look at the evidence for or against giving lots of protein. In health, we need about 0.8 grams per kilo per day of protein, depending on sex and age. And in acute critical illness, because cachexia frequently occurs, there's a loss of lean body mass, principally skeletal muscle, and negative nitrogen balance. Functional outcomes, even after recovery, are poor at 6 months. So it has been assumed that protein intake will counteract this. And all of the guidelines recommend between 1.2 and 2 grams per kilo per day of protein. However, this international comparison study done by the target trial investigators, which I'll discuss later in this series, found that patients only received 0.6 grams per kilo per day, half of that recommended level. Indeed, the number of calories delivered also fell well short of the prescribed quantity of around 2,000 calories per day. I showed this picture in the previous tutorial. It was from a single-center cohort study where indirect calorimetry was used to look at delivered calories versus resting energy expenditure and 60-day mortality. You can see in the left panel, the sweet spot for calorie intake was about 70% of resting energy expenditure. Below this, the patients were underfed. Above this, they were overfed, and both of these strategies seemed to worsen outcomes. Looking at the second panel, underfeeding with protein worsens outcomes, and it appears that generous feeding with protein at or above 1.3 grams per kilo per day improves outcomes. But be careful. These data were only collected from day 3 onwards, so they do not give us any great insight into early ICU nutrition. Nevertheless, it would seem that the stage was set to investigate a nutrition strategy that looked at generous protein provision in the ICU during acute critical illness and whether or not it improved outcomes. This is the EFFORT protein trial. It was published in The Lancet in February 2023. This is a registry-based pragmatic trial of 1,329 mechanically ventilated patients in 85 ICUs across 15 countries. The patients included were nutritionally at high risk over the age of 18, and what was compared was high-dose protein, 2.2 grams per kilo per day, versus usual dose protein, fewer than 1.2 grams per kilo per day, started within 96 hours of ICU admission and continued for up to 28 days or death or transition to oral feeding. The primary outcome was time to discharge alive from hospital up to 60 days after ICU admission, and the secondary outcome was 60-day mortality. In this trial, the investigators were not able to show a difference in hospital discharge time or mortality, but there seemed to be an increase in mortality in patients with acute kidney injury. And of course, the protein given was not individualized to protein needs. And there are a few points worth noting about the EFFORT protein trial. It was a pragmatic real-world trial. It was open label with doctors and nurses doing their normal practice. Originally, it was planned to enroll 4,000 patients with 60-day mortality, but because of COVID, everything had to change. The numbers had to go down, so they had to go to a softer endpoint. And in the end, patients in the intervention group only received 1.6 grams per kilo per day, and the control group got 0.9 grams per kilo per day. So while this was a great study with intriguing results, we needed more information. The investigators of EFFORT protein then went ahead and did a meta-analysis looking at all previous trials published in this field, adding in their data, and they found that higher protein intake was not associated with a mortality or functional benefit, but was associated with increased mortality in acute kidney injury. A post-hoc analysis of EFFORT protein in patients with acute kidney injury suggested that the harmful effects of high protein were seen in patients with acute kidney injury, but not in those who received renal replacement therapy. A possible explanation was that renal replacement therapy removed excess protein in the high protein group, thereby attenuating secondary adverse effects such as inhibition of autophagy. And their data was consistent with other previously published trials. It is possible that mortality is a poor endpoint, as with better nutrition, functional recovery is likely a better thing to study. Consequently, and simultaneously, a group from the Netherlands and Belgium performed a double-blind trial of high versus low protein intake in critical care using a validated quality of life scoring system, and this was the PRECISE trial. PRECISE was a multi-center trial of 2 grams per kilo per day versus 1.3 grams per kilo per day of protein in mechanically ventilated patients. Enteral feeds contained either 1.3 calories per mil and 0.1 grams of protein or 0.6 grams of protein. The endpoint was the Euro Quality of Life 5-Dimension 5 Health Utility Score, and that was measured at 30, 90, and 180 days after randomization. After 2.5 years, 935 patients had been enrolled. The energy intake was roughly equal between the two groups. As you can see on the left panel, standard protein is in green and high protein is in red. On the right panel, you can observe that there was a big difference in protein intake up to day 19. There was a big difference in health utility score, and it was lower in the high protein group. That means there was worse health-related quality of life in those patients who received high protein, and they also had more GI complications. Overall, there was no evidence of benefit from higher dose of protein in critical illness, and post-hoc analysis showed a statistically significant increase in time to discharge alive from the hospital in patients allocated to high protein provision. Subgroup analysis suggested that both women and medical patients did particularly badly. So why is high protein potentially harmful? Well, I'm going to quote from the paper. The mechanism underlying the deleterious effects of higher enteral protein doses is unknown. The increase in amino acid supply may have surpassed the capacity for protein synthesis, leading to increased amino acid oxidation and production of potentially toxic deamination products. Additionally, exogenous protein in the acute phase of critical illness may delay recovery by suppressing autophagy, the process of intracellular breakdown and recycling of old, damaged, or atypical proteins and other harmful substances from the cytoplasm. So where does this leave us? I think in the end, when we're looking at our target for the number of calories and the number of grams of protein, a good rule of thumb is that patients need just a little bit more than 1 kilocalorie per kilo per hour and 0.05 grams of protein per kilo per hour. Very briefly, let's just talk about the roots of nutrition. This is principally for those of you who may not have spent much time in hospitals or in the ICU. We get our energy from oral intake. We eat stuff and we drink stuff. A lot of our food contains water, so about half of our water intake comes from food, and the rest of the time we drink various different liquids. And that's how our bodies have evolved. That's how we get food into us, and that's how we've always got food into us. And without the oral route, our species wouldn't exist. But when patients become critically ill, they usually cannot swallow, they cannot eat, or they're not interested in eating. So we have to come up with alternative ways of getting calories into the patient. And classically, what we have done is place a oro or nasogastric tube. Nasogastric tubes are the standard. We put them into the nose, they pass around the pharynx and into the stomach, and we like to see the tip of the nasogastric tube beyond the diaphragm in the stomach. Occasionally, we'll pass an orogastric tube if the nose is blocked, if the patient has severe sinusitis, and most importantly, if the patient has a base of skull fracture. Alternatively, a PEG tube, a gastrostomy tube, can be placed through the abdominal wall to feed the patient directly into the stomach. The other way of feeding the patient is post-pylorically using nasal jejunal or nasoduodenal tubes, and these are placed often in the operating room by surgeons where they pass it along the bowel. Sometimes it's done radiologically, and then there are a medley of different toys that you can buy using magnets and all kinds of stuff to try and get that tube through the pylorus into the small bowel. It is really tricky, and not infrequently these things are pulled out or fall out. Alternatively, for example, if a patient has an esophagectomy, a jejunal feeding tube will be put in at the time of the operation, so the patient is being fed post-pylorically. If one is unable to feed or fully feed one's patient enterally, at some stage intravenous nutrition should be considered. This is known as parenteral nutrition. It is possible to provide all of the patient's energy, electrolyte, vitamin, and mineral requirements intravenously. However, the high glucose content of the feed may cause thrombophlebitis, so parenteral nutrition is traditionally delivered via a central venous catheter, preferably internal jugular or subclavian, in the ICU. For a patient who may require long-term intravenous feeding, a more convenient peripherally inserted central catheter is inserted just above the elbow. So in terms of routes of nutrition, enteral nutrition is our standard oral feeding, nasogastric or orogastric, nasojejunal, gastrostomy or jejunostomy, or parenteral through a central venous catheter or a PICC line. Now that we're clear on the different routes of administration, it's time to move on and look at the different controversies that exist regarding enteral feeding. In many hospitals, there is an almost religious zeal about using post-pyloric feeding tubes to enterally feed patients. On the one hand, you're pretty sure if you get a tube in that the patient will get their nutrition, although studies to date have shown that they don't. There's potentially less problems with gastroesophageal reflux and aspiration with this form of feeding. And also, the patients are less likely to have their feeding stopped for procedures or going to the operating room or going for scans. So it looks like it's all positive. The problem is these tubes are notoriously difficult to get in, and often when you actually manage to get them in to the duodenum or the jejunum, they accidentally get pulled out. Enteral feeding tubes are conventionally placed in the stomach, that's in the left panel, and they're inserted by nasal or oral route or by gastrotomy. However, in many ICUs, there has traditionally been a preference for feeding tubes being placed in the small intestine. That's the right panel. You can follow the tube along through the pylorus, duodenum, into the jejunum, and these are known as post-pyloric feeding tubes. Patients fed post-pylorically should achieve their feeding goals more rapidly. Is this true? You would think that there are lots of studies on this topic, and there were a good few studies in the 1990s, but they were small studies, and after meta-analysis, there was no benefit shown for post-pyloric feeding. Now, there was one multi-center trial by Davies and colleagues, this is from Australia, of 181 patients mechanically ventilated who had increased gastric residual volume within 72 hours of ICU admission. These patients were randomized to post-pyloric feeding versus just keep going with the enteral feeds and give some prokinetics, such as, for example, erythromycin. They could find no improvement in outcomes in patients who were post-pylorically fed. And that included things that you would expect, like vomiting, aspiration, ventilator-associated pneumonia, diarrhea, mortality. Nothing. Moreover, the expected advantage of post-pyloric feeding versus standard enteral feeding into the stomach of giving more calories didn't materialize. Both groups only got about 71% of their required calories. The patients who were post-pylorically fed did have a significant increase in minor gastrointestinal bleeds with a number needed to injure of 10. So for the majority of patients, gastric feeding should be attempted, and usually this results in achieving nutritional goals. For select patients who do not tolerate gastric feeding or where access to such devices are easily available for placement of post-pyloric feeding tubes, well, they may be beneficial, but you don't have to go out and buy all these toys that they sell at conferences to push post-pyloric feeding. When should you consider post-pyloric feeding? I think if patients have a huge amount of gastric residual volumes, if you check them in your practice of more than 500 mils, and there's evidence clinically of gastroparesis, yeah, you should consider post-pyloric feeding. Where there's current discontinuation of gastric feeds for procedures, patients who have necrotizing fasciitis or burns who are going back and forth to the operating room, because the post-pyloric feeding doesn't need to be stopped, and it shouldn't be stopped. If the patient has a gastric or esophageal injury, or they've had esophagectomy, certainly those patients should be fed with the feeding jejunostomy. And for patients who have, for example, spinal injuries, and for one reason or other they have to be nursed supine, then I think it's worth considering using post-pyloric feeds in that cohort of patient. For the majority of patients, gastric feeding is fine. And let's get back to that other question, the whole issue of gastric residual volumes. It seems to me that there is a religious belief in gastric residual volumes. This is when the nurses come to the bedside, they put a big syringe on the feeding tube and suck out whatever comes out of the stomach. And then at some arbitrary level, maybe 150, 250, 500 mils, who knows, it is believed that amount of liquid retained in the stomach is associated with increased risk of gastropulmonary aspiration. There is no evidence to support this contention. And indeed, since we started ultrasounding the stomach for anesthesia purposes, it turns out that lots of people have big residual volumes in their stomachs. The Nutritional 1 trial looked at 452 patients who were mechanically ventilated, randomized to getting gastric residual volumes checked every 6 hours or no check, and they decided that intolerance was 250 mils or more, or vomiting. They could show no difference in the ventilator association pneumonia rate at 90 days, 15 or 16% for both groups, the ICU length of stay, the duration of mechanical ventilation, infections, or mortality. But the patients who got no gastric residual volumes checked reached their nutritional goals faster. So it is probably unnecessary and unhelpful to routinely check gastric residual volumes. If there is a protocol in the ICU to check, I believe that withholding enteral nutrition if the gastric residual volume is lower than 500 mils is unnecessary. Checking gastric residual volumes does not reduce aspiration risk, but it does reduce effective nutrition if it acts as a trigger for stopping feeds. Let's look at enteral nutrition and bolus or continuous feeding. First up, something that is not controversial. Post-pyloric feeding should always be continuous. That's it. But what about the stomach? The stomach is a receptacle, so it makes sense to bolus feed it. But that is a little bit problematic in the ICU because it requires that people really pay a lot of attention and that they schedule those bolus feeds at certain times of the day. And the only data that really holds up against continuous feeding of the stomach is that bolus feeding is associated with a slightly reduced incidence of diarrhea, but really this hasn't appeared in any of the major studies of enteral feeding in ICU. And to me, there is no obvious benefit to bolus feeding the stomach because what we want to make sure is that the patients get their calories and that there is no excuse for not feeding the patient. So in my view, continuous gastric feeding is fine. So what about our patient Amelia with septic shock and acute lung injury associated with community-acquired pneumonia? She's a nasogastric tube in, so we will attempt gastric feeding, and that will likely be continuous. We won't routinely check gastric residuals. There's no reason to suspect that she has gastroparesis. We will target 25 calories per kilo and 1 to 1.2 grams per kilo per day of protein. But when will we start feeding, and when do we expect to achieve full calorie intake? That's for the next tutorial. In the meantime, let's review this one. In this tutorial, we looked at the basics of feeding the patient in the ICU, particularly looking at the amount of calories the patient should get, the amount of protein, and how we manage enteral feeds. Patients require 25 calories per kilo per day. This can be adjusted up or downwards depending on their body habitus, and they need about 1 to 1.2 grams per kilo per day of protein. More than that protein seems to be harmful. Patients can be fed enterally, pre- or post-pylorically, or parenterally. Gastric feeding is the preferred route due to the speed and simplicity, and it's unnecessary to check gastric residual volumes. enteral feeding can be continuous or bolus. In the next tutorial, we're going to talk about the timing of nutrition. Is parenteral nutrition safe? And when should we try to obtain isocaloric nutrition? I'll see you then, and I guarantee you'll learn something. If you're enjoying these tutorials, please subscribe at YouTube and leave some likes and comments. You can also follow me at ccmtutorials.org. Even if you just mention me to one of your colleagues, it would be really helpful. I'll see you soon.